Let's get started. This webinar is being recorded, so if you have colleagues who weren't able to make it, or if you just want to watch it over and over again because it turns out to be so fantastic, you will be able to do so. My name is Rachel Winograd, and I'm at University of Missouri St. Louis with the Missouri Institute of Mental Health, and we are collaboratively putting on today's webinar through the MOHOPE grant with NCADA. Brandon Costerison is here. Through the MORE grant with Dr. Claire Wood and Karen Wallace from DHSS, with the State Opioid Response Grant, with the Connecting the Dots grant, all sorts of opioid-related grants that exist in Missouri. We're sort of joining forces and putting our heads together to put out information that we hope is useful. So today, the focus is going to be a discussion across care settings, specifically EMS, hospitals, and substance use disorder treatment settings, about the intersection of COVID-19 and people who use drugs and overdose. What does care look like? How are we responding? What is happening in your setting? And what advice do you have to give to those around the state who are trying to grapple with these two competing public health crises? Most of our speakers are from the St. Louis region, but this information should apply statewide. We are a hotspot here in St. Louis, both for COVID-19 and for overdose. So we have some experts who are generously willing to share their experience and insights, but we'd like to keep this as a roundtable dialogue, so to speak. So please utilize the chat. Speakers, if you're able to see the chat and want to pause and say, answer the question while you're talking, feel free to do so. Otherwise, we'll try to transition between speakers and make sure that questions get addressed. We're going to lead off with Sam Vance. I'm just going to introduce everyone really quickly and then hand it over. Sam Vance is the chief at the Bureau of EMS with the Department of Health and Senior Services. Thank you so much for joining us. He's going to hand it over to Dr. David Tan, who is the EMS section chief with Washington University. Then he will hand it over to Dr. Evan Schwarz, who's an emergency medicine, toxicologist, and addiction medicine physician at Barnes Jewish Hospital in St. Louis. And then he will hand it over to Cori Putz, who's an executive vice president with Preferred Family Healthcare, a very large treatment organization with a footprint throughout Missouri and multiple other states as well. So without further ado, let's hand it over to Sam Vance. And Sam, please feel free to share your screen. Great, it's working so far. Okay, I will mute myself. Thank you.
All righty. Thank you, Rachel. As she said, my name is Sam Vance. I am the chief of the Bureau of Emergency Medical Services with the Missouri Department of Health and Senior Services. And the Bureau of EMS hasn't done anything specific in our response to COVID-19 that has been directly related to overdose events or individuals with opioid use or other addictions. However, there have been some waivers of statute and PPE shortage that could affect overdose response and other interactions with people with opioid use disorder. The Bureau of EMS received a waiver of statutes that allow emergency medical services to triage 911 emergency calls by prioritizing the type of calls that need the most urgent transport based on the high call volume and the potential for emergency medical services to respond based on staff shortage and available ambulances. For those calls deemed non-urgent, the patients would be allowed to arrange an alternate form of transportation to the hospital. This triage should be in protocol with the ambulance services and approved by the ambulance service administrator and medical director. And this waiver allows providers to make their own determinations whether a bona fide emergency exists for purposes of providing needed treatment to patients. However, while we haven't received any reports of this waiver being used inappropriately, I can see the potential that an individual with substance use disorder or a drug overdose could potentially be overlooked. And we mustn't forget that those with substance use disorder still need our help. Nationwide, there's been reports that some EMS personnel have been more reluctant to administer naloxone or Narcan due to fear of potentially contracting COVID-19. But again, the Missouri Bureau of EMS hasn't received any reports of this happening here. EMS personnel who have adequate PPE of gloves, gowns, and facial protection should still consider the use of intranasal naloxone. If intranasal Narcan isn't available or feel the use of intranasal naloxone poses too great a risk, there is another lower risk option. Intramuscular naloxone can be injected into the thigh muscle far away from the nose and mouth, thereby reducing the risk to the rescuer. It has an onset action of about 2 to 5 minutes. There's also auto-injector devices that can be rapidly and safely used by both EMS professionals and the general public. Alternatively, it is within the paramedic scope of practice to administer naloxone through intramuscular injection using naloxone supplied in a vial with a syringe and appropriately sized needle. Substance abuse disorder, and specifically opioid use disorder, affects many Americans, and we must assure that our EMS personnel are able to safely intervene in the case of an opioid overdose. And it's critical that naloxone continue to be administered during this time period as needed, and its administration be done in a manner that reduces risk of COVID-19 transmission. And the last thing I'd like to touch on is the mental health and opioid and other substance use by our EMS personnel. We continue to see this as an issue and have dealt with cases of EMS personnel and opioid use and abuse during the COVID-19 crisis. In the midst of two concurrent national public health emergency declarations, the opioid crisis and COVID-19, compassion fatigue and other associated mental health issues are a hidden predator amongst our EMS personnel, as well as other first responders. In a 2018 study, the Substance Abuse and Mental Health Services Administration found that 69% of our EMS professionals and other first responders reported that they don't have enough time to recover between traumatic events. Given this, EMS personnel are more likely to suffer from depression, PTSD, suicide, and substance abuse. If you're an EMS agency administrator, implement training and resources now so your employees will be around to thank you later. Employ tactics and strategies that are fluid and can be applied to any emerging threat, national public health emergency, or just the inherent disposition of the job. If you don't know where to start, I would suggest that you try some of these ideas, and if they already exist, that you would expand upon them. Which one is the employee assistance programs. Now is a great time to remind our personnel of this resource and how to access it. Debriefing sessions for difficult calls and trying days warrant a willing ear. 24/7 virtual peer support groups. And in this world of social distancing, first responders need that human connection as well. Public recognition. Engage the community virtually through social media. Much of the community is at home, and what better time to engage them with CDC guidelines and acknowledge valor in action. And incorporate awareness, education, and resources into academy and in-service training. After you have a chance to breathe and several moments of clarity, don't forget to continue these efforts. And I would just like to close by letting everybody know that this is EMS Week, which National EMS Week is May 17th through the 23rd. And it is a time that we like to recognize and acknowledge the work that all of our EMS personnel are doing, not only throughout the nation, but especially here in the state of Missouri, and especially in these unprecedented times that we're facing right now with the COVID-19 response. So thank you. And I will turn it over to Dr. Tan.
Thank you, Chief. And yes, to echo Chief Vance's sentiments, I'll take a moment to wish any first responders that happen to be watching a very happy EMS week as well. Chief Vance and the Bureau of EMS have been incredibly supportive of pre-hospital providers and first responders during the COVID crisis, and particularly as it intersects with substance use disorder. I will say that, admittedly, even among EMS physicians and emergency medicine specialists, there is some controversy over what constitutes an aerosol generating procedure or an AGP. And when you consider that it is thought that COVID-19 can be transmitted through the air, through aerosolization, as would happen if a patient were to cough or sneeze and put infectious particles in the air, we still don't know exactly how long such infectious particles may be suspended in the environment, but we do know that it may be suspended for some time. And so any kind of medical procedure which may generate a cough or a sneeze gives EMS professionals some pause anyway. And certainly putting a tube down someone's throat to breathe for them as an endotracheal intubation, but also the intranasal administration of Narcan is a potential source for causing someone to cough and sputter or sneeze as they were to awaken. And so because of that, the majority of EMS medical directors around the region, if not the state, have modified their opiate toxidrome protocols to switch to intramuscular Narcan. As Chief Vance mentioned, one of the options is to do intramuscular Narcan, say in the thigh, well away from the head and face, instead of doing intranasal administration of Narcan. And so while the state certainly does not mandate that, I think a lot of medical directors have decided that that's probably the safest thing to do for the time being until this particular COVID crisis is over, and or we understand a little bit more how the infectious particles are spread. And along those lines, one of the biggest challenges that we face now as we begin to understand more about the disease is that there's still so much we don't know about the disease, and that in fact it can be a great imitator, so that even if the patient does not exhibit the classic signs of fever, cough, chill, difficulty breathing, we are finding that some patients may actually test positive for it anyway. So in that regard, our first responders are basically treating every patient as if they are a carrier or they may have it. And so even if it is even if it comes out as an overdose call and there's no signs or symptoms of illness, they kind of have to make sure that they approach that scene as if the patient does have COVID-19, which has changed our response to overdose calls to mean that we have to wear the appropriate PPE regardless. And I will say that part of the reason why the switch has been made to IM Narcan instead of the intranasal form at this time is because, again, while we think that it's usually transmitted through droplet nuclei, it still may be airborne. Hence the N95 and the goggles as far as PPE goes. I think the message that we've been trying to give to all of our first responders is that as long as you have the appropriate PPE, you're pretty safe. In conversations with our colleagues from Seattle, King County, in Washington, who were among the first hotspots in the country when this all started, they have been able to give us evidence that their first responders, when they're using the appropriate N95 and goggles and gown, gloves, are able to avoid contracting the disease as part of their 911 responses. And so one of their take-home messages to us as we began to see hotspots in Missouri and the rest of the country was that we really ought to trust our PPE. And so that applies to other conditions like doing CPR on people and cardiac arrest, not just things like cough and fever and substance use disorder overdose calls. So I think that's one of the things that has helped alleviate the anxiety among our first responders, is making sure that they have appropriate instructions for donning and doffing their PPE, and of course that they have enough. And one of the main issues that we've had, that we continue to have, is the ability to maintain a sustainable supply of necessary PPE to do the job. And so employing things like PPE conservation strategies and employing scout functions. So in other words, instead of putting every crew member in full PPE, you send someone in to make sure that they do or do not have any signs or symptoms of the disease, or that they're not going to need immediate resuscitation. In many instances, that can save a lot of full PPE usage. And Seattle, King County did that for quite some time. They're still doing that, to my knowledge, and they are able to help conserve PPE for other calls in that regard as well. I would say that overall, and my colleague, Dr. Schwarz, may talk about this as well, but about emergency department volume being down overall. But I'll tell you that also applies to EMS volume, which means that overall volume, including overdose calls, has been either the same or less. Certainly not, at least in our region, it doesn't seem that our agencies are substantially higher, at least reporting overdoses. And so we are still very diligent about providing them the help they need. And as Chief Vance said, whenever we do respond to these calls, the IM Narcan is working, and we are still trying to get them to the resources and the help that they need, and transport them to the emergency department if they'll accept it. We have had instances where, after they wake up with the Narcan and they're completely awake, alert oriented, and with it, they have the same anxieties that everyone else has, and they don't want to go to the emergency department because they're afraid of going to a place where there may be a lot of COVID infected patients. And so we then still try to make sure that they have access to follow-up resources if at all possible. But then if they do go to the emergency department, that is where my colleagues in the emergency department, as well as our toxicology clinic, et cetera, are able to then take over and again, try to make sure that they don't get lost in follow-up. So with that, I will turn it over to my colleague, Dr. Evan Schwarz.
Thank you, Dr. Tan. Can I jump in with a quick question or two?
Sure.
And participants, feel free to speak up with questions or write them in the chat. Dr. Tan, have you and your colleagues noticed any differences in the overdose scenes when you come upon people? We've heard anecdotally that more people are, using in their homes, or what are you noticing when you come on scene? Who's around? Where is it happening? What else could we do?
Yes, I think that's a valid point. It's people, because of the social distancing and the isolation and stay-at-home orders, I think instead of having these calls in public places, the ones that we have seen do tend to be at home more. Obviously, invariably, someone is going to look after them, look for them, or find them, and so they may be. There may be some delay in getting help to them, just because it's not unusual anymore to go for hours without seeing somebody in social isolation at times. But as far as the demographics of it go, I will agree with you that it is largely residential now instead of in public places like we have seen in the past. At least it's leaning that way more. But it is definitely fewer instances where it's in the setting of a large crowd or a large gathering. it is in situations that are more socially isolated because of the circumstances.
Thank you. Okay, so we'll hand it over to Dr. Evan Schwarz.
Thanks. Let me see if I can get the slides. Let's see. All right. Sorry, I think it's showing the wrong screen, but in the emergency department, we're not doing that much differently. The biggest thing we've had to try to do is how to replace the recovery coach in person. So what we were doing is we were activating a recovery coach that would come into the department and speak with the patient directly and help them arrange follow-up as well as fill medication and give naloxone. And so really the key has been how have we been able to replace that person. So we're actually moving towards a virtual format. For the past couple weeks, what's been happening is we activate the same service, but we get a follow-up appointment and give the follow-up appointment to them. So it meant the clinical teams had to do a lot more of the discussion with the patient about what's going to happen, the benefit of treatment, and kind of calm all their fears and kind of try to get that buy-in. And there's really little doubt in my mind that we don't do that as well as the recovery coaches do. And so hopefully now with them being able to do it virtually, we have the benefit of their knowledge and their knowing how to do this and how to make that connection, but still being able to keep them safe and not having to come into a bunch of emergency departments. So likely what it'll look like is they get a Zoom link and we have a bunch of iPads and someone will bring an iPad into the room and connect the patient with them with an iPad. And after that, everything would be the same as a face-to-face conversation. If the EPIC program, for whatever reason, which is the program we use to set up follow-up with them, if they weren't eligible or whatever other issue they might have, we've also been able to find providers through many resources, including kind of the NomoDesk website, which has a bunch of physicians doing virtual visits and stuff to try to help the patients. We're still able to prescribe buprenorphine. One thing that has changed is ourselves, as well as many others throughout the country, have discussed about longer prescribing periods. So yeah, in the past, we might do more limited prescriptions just to make everybody feel a little more comfortable, letting everybody know it's okay to prescribe much longer periods even to a new person, just to ensure that they have enough to get to their follow-up appointments, especially since once they get to their follow-up appointments, it can still be a little difficult sometimes for some patients to get medication. The one area where we are kind of struggling is with naloxone. So in the past, the recovery coach would bring in naloxone that they would give to the patient. Now, technically speaking, since this medication is not coming directly from the pharmacy, we're not supposed to give out medication. So technically speaking, what was supposed to happen is as the patient was leaving with the recovery coach, they were supposed to hand them the naloxone. Now, I'm not saying this happened, but it's possible that while they were in the hospital, the recovery coach just gave them the naloxone and said, put it in your stuff. And maybe that happened so that the patient did have naloxone. With them not coming to the hospital anymore, at least for now, they obviously can't do that. I know we did have a bunch of naloxone that was dropped off with us, and I had it in a storage space here, and I was gonna hand it out to patients. And I was told by legal that that was more than just really frowned upon. So, we are prescribing naloxone. We do tell patients where they can get naloxone for free, but that's still not nearly as good as them leaving with naloxone in hand. And from speaking with other hospitals, they are still kind of suffering with the same thing. The unhoused population that potentially does have COVID, from my understanding, they do have places that they can go that kind of isolate them a little bit more. So they have some resources, but otherwise are treated pretty much the same as far as their opioid use disorder. In the hospital ward, it's the same thing. So we start people on buprenorphine or methadone in the hospital. We can still start them on medication. Once again, the recovery coach really can't come in to see them. So we've discussed using some apps that they can use on their phone, as long as they have a phone that has some smart capabilities to it. They can use the free Wi-Fi on campus and kind of use those apps to provide a little cognitive behavioral therapy and a couple other things. Upon discharge, our mobile pharmacy actually provides the buprenorphine. Obviously, it does not provide methadone since that would be against the law. Social work on the floor can pay for naloxone, so those patients are leaving with naloxone in hand. And while we can't do the virtual appointments with Epic on the hospital floor, just because we don't have the iPads to connect to every single floor and area in the hospital, we can make their appointments over the phone, and they could theoretically talk to the recovery coach over the phone. And then we do have a small outpatient clinic. So this is kind of the one real big silver lining. This is not an OTP that we run here. This is a smaller clinic. But what I will say is this, I think, has been a nice thing, and things are much more convenient for the patient. So we have been trying to do telemedicine for a while, and this really, with relaxing of regulations and not wanting to have patients that didn't need to come to the hospital, we've been able to have either Zoom type conversations and appointments with patients or conduct them over the phone, which has made follow-up and everything easier for the patient. Because buprenorphine is a Schedule 3, we can call that in, and we'll set up a system as far as drug screenings of them being able to just go to a Quest laboratory that's closer to their house. So it does take a little bit of time to kind of change how you have that conversation. You lose some of those cues you may have in person. Most of them you can pick up still on a video chat format. When it's over the phone, it is a little bit more difficult since you can't see the patient, obviously. But I think it has been pretty successful in connecting them, making sure they're still on medication, and making it a little more convenient for them without having to have them come to clinic, especially since many are afraid to come to the hospital. With that, I will say, if you need to come to the hospital, it is perfectly okay to come. We've made it pretty safe. As far as I know, we haven't had any, patient to provider transmission of COVID in the hospital. And if you're suspected of COVID, you basically either get put with other COVID patients or in a private room. So the chances of a patient-to-patient conversion is less, and everybody's getting masks and we're cleaning everything pretty well. So I don't want to sound alarmist either, like it's unsafe to come to the hospital. But honestly, we try to limit things to keep it safe. And really, that's all I had.
Thank you so much. Let's take a minute and address some of these questions in the chat before we lose them. So from Liz Connors, we've heard information about increased EMS calls for overdoses in states like Ohio. For Dr. Tan, can you speak to why Missouri may not be following this trend?
That's a really good question, and I would clarify that I would say that for the agencies for which I provide direct medical oversight for, we haven't seen that giant spike we were afraid of seeing. Before I say that for the whole state, maybe I should check with Chief Vance to see if he knows of any epidemiological data, whether or not Missouri is following that same trend as a state. But for our region anyway, or the areas that I provide oversight for, I haven't seen that. So I'm not sure if Chief Vance knows that answer or not.
So I unfortunately do not have any data on that at this time.
So
if Missouri were not following the same trend as Ohio, I wouldn't be able to speculate why that is. I would like to think that it's because we have programs like EPIC and a very active EMS systems that try to get people the help they need, so that we actually don't have very many repeat offenders, so to speak. And I'm hoping that it's because we have a more supportive infrastructure, maybe, that would be making a difference. But that would be pure speculation.
We saw some recent data from the St. Louis City Health Department that had preliminary numbers from St. Louis City EMS showing there had been an increase in overdose calls specifically starting in March and through April. I don't know if anyone from the health department is on the line. That might be something we're just seeing in St. Louis City. We certainly don't have statewide data. but we are seeing that locally. One reason I think, Liz, I mean, this is entirely all speculation on everyone's part, right? But we've relied a lot on mass naloxone distribution efforts and community saturation for peer-to-peer reversal and families and friends reversing each other. But with social distancing and people keeping apart, you're just that much less likely to be near someone who has naloxone. So as Dr. Tan said, they're more likely to come upon people alone or with one or two family members. You're really decreasing the chances that someone could reverse you on their own. And we know from our data collection on overdose events that most people don't call 911 if they have naloxone on hand. So maybe they're calling 911 instead, but hopefully it's happening in time and EMS is getting there and saving that life. Okay, well, let's turn it over to Cori Putz to get outside the hospital and talk about community-based substance use treatment.
And I'm going to try and be as smooth in sharing my screen as all the prior people were, but I probably won't be. Well, so far, so good. All right, I'm going to move you guys out of the way for a minute. First, I really would also like to say thank you to, EMS and the first responders and, and I know even the hospitals just going above and beyond throughout COVID. So thank you for that. It's very much appreciated. Just to talk about the substance use treatment provider, and obviously I can only speak for Preferred Family Healthcare, but nothing was linear or sequential with regard to our response to COVID hitting. So, it was so many things happening at once that I can only liken it to, and it's not to sound trite, but trying to drink from a fire hose while simultaneously trying to put the fire out. It was very, very chaotic initially, and really hitting on that March 13th, which just happened to be a Friday. Most of what we implemented really took place and was in place over a period of 7 to 10 days. And that was in mid-March. As Rachel mentioned, PFH is a large organization with 3,500 plus employees and multiple service lines in 4 states. So it took leadership from all, of the different divisions and service lines to come together, and representatives from, corporate compliance, HR, all of those different areas to truly make it successfully transition to remote service delivery. In this, our number one priority was to minimize disruption to services, and in particular medications that our clients rely on to sustain recovery, and also simultaneously ensure staff safety. Every decision really included carefully weighing out cost and benefit to our clients, individuals in need of, and trying to still seek and get into services along with staff safety. We continued to operate our medically monitored inpatient detox, our recovery houses, 1 residential care facility, a couple of domestic violence shelters, and our community services from throughout the start, and those were the programs that we said we are going to continue to make sure that we're taking and people have access to those levels of care and those services. We did defer admissions into our residential settings. On March 13th, we were operating 14 residentials that were all at capacity, both adult, adolescents, some women and children. And really our decision to defer admissions into those residential settings was because we had such a shortage of PPE. And we needed to direct what PPE we had access to really to the locations and programs that I mentioned previously. So we continued to keep the people that were in res to allow them to go for their continuity of care, but we just did not admit anyone new into those environments. Maintaining access to medically monitored inpatient detox really was a priority, knowing that these individuals are our highest at risk for overdose and other medical emergencies, and we knew they would likely land in the emergency room if medically monitored inpatient detox wasn't available. So we did move forward with that. We developed and implemented, COVID-19 clinic protocols along with, or which included COVID screenings prior to permitting entry into the building. We did our best to ensure the social distancing and really provided clients and staff with surgical and cloth masks. And this was before cloth masks were all the rage. So it was kind of ahead of the time at that point. We immediately sent our prescribers to work from home in an effort to keep them healthy and ensure ongoing access for patients to needed medications. Our med providers were set up to deliver telehealth pre-COVID, so this transition, from a technical stance went very smoothly. PFH does deliver a large number of services to adolescents, and most of them are school-based. As you know, most of the schools were on spring break when all of this hit and determining whether they were going to come back or not. And obviously they did not come back. Our local leadership maintained communications with key contacts at a number of the school districts, and the school districts were wonderful. And they actually worked with us collaboratively really to promote the virtual services and groups in tandem with them going to a virtual classroom and a virtual platform as they returned. So that was just a great partnership and did keep access for some active adolescents. Transitioning 2,000 plus staff to work from home was no small feat. PFH did already utilize a couple of different video conferencing platforms that were HIPAA compliant. So that was nice to be able to do that, but we usually use them for medical visits and like family therapy. So we had a learning curve, and not to mention a tech equipment shortage because a lot of our offices had desktops rather than laptops. And so getting our hands on the audio equipment that was necessary, especially for those staff that had children now at home, to ensure confidentiality of sessions that they would be facilitating. So it was a big to do, and we ended up having to designate, like a whole logistics department to get things delivered and shipped and moved around the 4 states. Regulatory agencies were really quick to come out with guidance and allowance for telephonic services, plus the flexibility for use of audiovisual platforms to meet the clients where they need. And this really did lay the foundation for us to continue to serve most of our active clients, but we still had to contact all of our clients to inform them of the changes and what to expect and how to best connect for continuity of care. Things were changing by the hour, and every bit of incoming information was like necessary and relevant. And if it wasn't for entities like MIMH and, and some of the other coalitions and groups around the state helping us, they really stepped up to help sift through and create summaries, which, was just magnificent. And the regulatory entities that stepped up providing information, support, stability, flexibility, some cases funding, that really did help us sustain that connection with our clients and keep our staff safe. So if any of you are on this today, thank you for that. We really did appreciate that. As we transition to services from in-person to remote, we set up some internal reports and communications to monitor the shift of in-person to remote services. And then subsequently, we also started monitoring total daily visits broken out by adolescents, adults, and CCBHO, which is what operates in the northern part of Missouri. You can actually see here, and I don't know if you can see my mouse moving, but you can actually see where the CCB, or where, we had this dip in the middle of March, and really the adults, everything, all services dipped. But then subsequently, once all the staff were set up to do the remote services, you see this steady increase for adults and for our CCBHO. But we see the residual effects of kids not being back in school and not being in, the juvenile justice. They're not operating, and that's where a lot of the services take place, and intakes and referrals come from for our adolescent population. So it's interesting that leveled off and stayed level. I'm going to go back to that for a second. We have seen a slight decline in our admissions, and mostly though our admission has declined because we're not having people enter into residential for a period of this time. And then also 70% of a decline of our admissions has been in that adolescent population, which is concerning considering, the fact that, for consistently in the prior, months, we had high levels of kids in need, and that need did not go away. So, it's just something to be thinking about of how can we still get the word out, number one, that we're still here, but that how do we connect with that age group in particular, which seems to be struggling more so than the adults served through our other programs. We are doing residential admissions now. We opened up our residential admissions 2 weeks ago. And so, all of them really went to full pretty quickly. We're operating 6 of them right now. And then we're have plans to bring more back online as we see how things go with the state opening up. While our med providers were set up for telehealth, our nurses and support staff on site were not, in that we had one telehealth station at our program sites. So, we had to quickly change workflow and get equipment right into these hotspots where we knew we had to get the nurses and the staff connecting with the medical providers. We did continue in person, kind of that pre-med nurse workup for our clients whenever possible. And we still are doing that with, using social distancing and the masks, so long as everyone is asymptomatic. We do the COVID-19 screening for people to come into the building, and there have been some clients who are not permitted to come into the building, along with a caterer on one occasion. So we waive the urinalysis, and the patient is able to connect with the med provider via phone or video. One thing that we have heard from more anecdotal, we have not seen this yet in our surveys, which we're working on sifting through, but preference from both the patient and the med provider perspective is that they like the audio and visual component more so than just the telephone. And some of it just speaks to being able to read some body language, some engagement, and being able to connect and feel like that, relationship is there. The patients who have had established relationships with our med provider prior to COVID have adapted easily to whether it be audio, visual, or telephonic. So really, this is pretty more specific to the new patient via audio only. However, interestingly enough, as much as, the audio visual is the preference, what our providers have talked a lot about is that the reliability of technology or lack thereof is, their sessions will start as audio video, and then due to the connectivity getting disrupted or interrupted, they end up turning over and moving into a telephonic session. And so they adjust to it and stuff, but it's clear that we don't have, some of the infrastructure in place to support that audio visual at high levels. Our med providers readily adjusted to some of the eased restrictions, spreading out med visits, writing lengthier prescriptions, increasing number of refills, allowing for early fills, and that was really significant for some of our individuals that were on buprenorphine products. More the anxiety and concern surrounding the fear that I might get quarantined or have something happen that I can't get my medication. So that early fill really, really helped to be used that way. We do have a handful of patients that have been on Vivitrol that actually reported symptoms of COVID or had a positive exposure through living with someone else in close quarters, so they weren't able to come back into the building. And again, some of this is being rectified with access to more PPE now, and adequate and appropriate PPE, which we didn't have at the time. But, while not ideal, the med providers have been prescribing the oral naltrexone to those individuals. So they're trying to not disrupt their medications as well. As of 2 weeks ago, I think I noted we're several residential centers are admitting new clients with COVID clinic protocols in place. The majority of our outpatient services are being delivered remotely. Not all clients have cell phones, tablets, or computers. Imagine that. So our CSSs work with the clients to help them obtain a cell phone and some minutes. And then we have a good number of sites that we actually have tablets and hotspots, and that's really thanks to some funders that actually helped us with some early on emergency funding to purchase bulk tablets to be able to use in this manner, but they're available to clients and they can come into our parking lots to still connect with us and access services when they can't just come into the building. Staff also are engaging in some community outreach. They've been so creative with like buckets that have some essential items in them, and then service schedules. And then they do just a check-in with social distancing, encouraging clients to participate in the virtual services. Weather permitting, we facilitate some services outside as well. And I'm probably getting short on time, aren't I, Rachel? Oh, good. While this time I'm about to wrap up, this is the last slide. But while this time really has been challenging, it really is, it's such an amazing time, and it's really exciting because, this pandemic, kind of like what Dr. Schwarz said, this is the silver lining, and it has catapulted us into a world, of virtual services, and no doubt that it's just going to reshape mental health and substance use treatment services for years to come. We had done virtual services, but we were not doing them at this level or this magnitude where they were in lieu of or in place of in person, which is significant. And so, we expect that we will end up with a hybrid model of in-person and virtual services based on kind of individualized need and preference. But, and we're doing surveys and looking at all this data, but, I think that, that we're really, when we think about the fact that we've only done this for 2 months, and we're going to be able to delve in to see what are some of our outcomes and what's some of our retention with clients, because we're seeing clients show up better and be engaged more when they have the option of that remote connection. And, and obviously participation in substance use treatment in particular, that, engagement and that participation has always been challenging. So, so this just kind of gives us more tools in the toolbox to serve this population. So I really can't wait to start looking at some of the outcome as we get closer to go. I do think, going forward, we're going to have to advocate, for and build some infrastructure to really ensure that all clients have access to the needed tech devices, Wi-Fi, and cell service, because it really is available inconsistently. And so being able to look at this from, sustaining it longer down the road, and advocating for that telephonic service based on some of the reliability factors with audiovisual, even if it's just as a backup. I think we're going to need to do that to make sure, again, that nobody ends up going without. So, and that's kind of where we are today. So I appreciate you inviting me to share, and I'll turn it back over to you all. Thanks.
Thank you so much, Cori. That was fascinating. We have a question from Joellen Patterson in the chat box. Do you have any restrictions regarding admission to residential admissions or protocol for the person to be admitted? For example, a negative COVID test.
We are working on, sorry, I'm trying to now get back. I don't know if I'm still sharing my screen or not.
But we are.
I am still sharing my screen.
I'm going to stop it. There we go.
Thank you. I have no idea. So we do the verbal screening, and then we, with the list of questions and temperature taking a couple times a day. And I just actually responded to an email today requesting some tests in order to start, and we named all of our residentials and our community services, because we're understanding that some testing specific to congregate settings in particular, that we're going to be able to start doing that. But at this juncture, no, we have not done any actual testing to determine. There is some guidance out there from National Council, which was very helpful with regard to continuing to serve during COVID. And for example, you might be asked, when we have 2 beds in a single, in one room, one person sleeps with their head at this end of one bed, and then there's the space in between, and the other person needs to sleep with their head at the opposite end to maximize space between the two. At nighttime, we have very specific showering hours, between, because of the way we don't know if this hangs in the air, we don't know how it's passed. So there's some specific guidance to that. And asking our clients to adhere to the social distancing and willingly understand, here's the here are the protocols in place, and we need you to be willing to commit to that if you're going to come into one of our residential settings for care.
I'm trying to stay on mute as much as I can because I got a noisy baby. He has some questions, but he just can't quite put his finger on it yet, how to verbalize. But the chat is open if people want to put questions here. You know, something that many people are talking about right now are the changes in the drug supply. So wondering if any of you would like to speak how that is or is not impacting your work, if you're seeing it or if you're not. You know, what we've heard from some is that there's really a drought right now, very hard to get fentanyl specifically, which in the short term might feel like a good thing, but has all sorts of negative ripple effects as people get desperate and try to stretch a supply, maybe use other synthetic or dangerous substances. And then of course, when fentanyl comes back, maybe it's already happening. We fear we'll see a surge in overdoses because people's tolerance is down. Are you guys hearing anything like that, seeing that with your patients?
You know, we were already seeing, you know, kind of an increase with methamphetamine and cocaine, so the stimulants in general. But you know, the staff and when I'm visiting, and they're not, you know, they're still, when we do the, you know, substances used, you know, they are saying they can't get fentanyl, but they're definitely still getting heroin, but saying that, you know, it's just not, they have to take more. So that's the danger in this, is because it seems to be cut a little bit in order to just achieve that high or avoid withdrawals. So.
One thing too, Chief Vance, I don't know if you would want to speak to this, but I know you've recently launched the statewide standardized EMS data system, and the extent to which this could be used to evaluate sort of overdose trends, along with like how COVID is affecting it. You know, I'm sure you guys are slammed right now, but you know, if you wanted to talk about the potential for this, you know, in the future.
Sure. So we did recently, within the last couple of months, launch the NMSIS Elite, or the NMSIS 3.4 system for gathering and our patient care reports. As far as the data elements are concerned, there are some data elements specific to opioid use and the administration of Narcan or naloxone. Since we are still relatively new with this system and the collection of our reports, we don't really have robust data to share yet. Currently, we have 222 EMS agencies within the state, and we have roughly 180 agencies that are submitting data now. So it will be a tool that we can use here in the very near future to provide that on opioid use. And as you mentioned, for the COVID-19 data, those data elements are ones that NMSIS, along with the NHTSA Office of EMS, created. And we have just implemented those COVID-19 data points into our system as of this last Friday.
And I'll add, speaking as an EMS medical director, that I'm very excited about the potential uses for this data. I think the Bureau of EMS and EMS medical directors in the state will be able to hopefully turn this data into actionable information so that we can actually do something with it and concentrate either on hotspots or identify areas of education, both for patients and for providers. But this is a real game changer, I think, having a uniform data set.
So I have a quick question. We know that there's an intersection between respiratory challenges and overdoses. And right now I was wondering what we're seeing either on the EMS side of things or in the ED between that kind of co-occurrence of people that might be experiencing sinus infections right now, severe allergies and taking respiratory depressants like Benadryl, and those individuals who have respiratory complications as a result of COVID-19. What are you seeing anything with that intersection that's different than historical, or is that kind of trending as it normally does?
Well, that was the initial trouble when this all started. We were actually still in the middle of influenza season, just plain old flu season. And so at first, there was this belief that it was rare to have a co-infection where you have COVID-19 and influenza until we started seeing that. And then now we knew that could, in fact, you could have co-infections. As social distancing and other isolation measures began and quarantining, stay-at-home orders began to take place, we did see a rather precipitous drop, not only in as far as flattening the curve goes, but also in other everyday viruses, including influenza and plain old coronaviruses that circulate in the community. But now, as you said, we're heading into hay fever and allergy season. So the answer is yes. That is a confounding factor when you're trying to decide who has symptoms consistent with this disease versus who is just having allergy symptoms. And especially since we know now that people with COVID-19 don't always have the classic fever, cough, and shortness of breath.
Yeah, especially, I mean, rhinorrhea, nausea, vomiting, kind of myalgias, can be opioid withdrawal, can also be some type of viral illness. So it can be difficult. I don't know that it's changed too much aside from just the fear that if this is COVID and the patient could get worse. At least in the ED, in the hospital, we have the benefit of starting buprenorphine or methadone, and if that seems to fix it, we kind of have our answer there. But overall, it's in some ways very similar to what we've kind of always dealt with.
Yeah, there's a question from Sarah Parks about is there going to be increased access to auto injectors in the hands of social service agencies the same way there's been access to intranasal naloxone. And Brandon, yeah, you answered, thank you. He can't speak to auto injectors. However, I have an ample supply of vial and syringe intramuscular naloxone. So this actually, thanks for bringing this up, Sarah. This is a great excuse for us to get even more comfortable with intramuscular naloxone, specifically the vial and syringe. That it's way cheaper. In fact, we often get it for free from Direct Relief. People who use drugs have been using it this way for decades. The Narcan nasal spray is like the new fancy thing on the block, but it's way more expensive. So if you can get you and your staff to use a vial and syringe through the various grants that are represented on this call, we can certainly load you up. That does not include auto injectors. So Sarah, if that's really literally what you were referring to, the Evzio auto injectors, those are like $4,000 each. They're exquisite, but nobody is really providing them anymore. For a while, there was an expired supply circulating that folks were giving out, but I think that's tapped. But thanks for bringing that up. Also, Christy Ivory from Queen of Peace just sent an FYI that they're admitting residential clients again, but they've decreased their census, so no more than 6 at a time. And Audrey, hey Audrey, requested a copy of the slides. We will collect the slides from the speakers, so we'll shoot you guys a note for that, and then Claire Ward will figure out a way to send this and a link to access the recording after this is over, once we get our heads on straight. It's 4 o'clock. Thank you so much to all of our presenters and to your teams and staff who are out there delivering care, and thanks to all those who attended. This was really informative. Thank you all.
Thank you.
Hey, thank you.